Newburgh United Church. I am Reverend Barbara Mahut, and I have the great pleasure of serving this congregation along with our sister church, Centreville United. I want to welcome all of you here this evening. We are grateful that you are here, and it's really nice to see a full church. It's not quite this full on Sunday morning, so it's really good to see you here. Tonight, for us, is another opportunity in our efforts to better understand the world around us. Some of you will recall the roundtable discussion in which we had representatives from Centreville House, Napanee, Onguanada, Kingston, and Morning Star Mission in Napanee a few months ago. This gathering was done in our continuing efforts to address the needs of people in vulnerable sectors. We invite you, if you have any suggestions on topics or speakers for future events, we would love to hear your suggestions. And there are cards in your pews with pencils that we invite you to write questions down for Dr. Philpott tonight. Also, you might use the other side for any suggestions of speakers or topics for our future. Also, this evening, you're receiving brochures handed out. More are available for anyone who would like to take more with them, just to letting you know about the activity of our church, our active life of our churches in Newburgh and Centreville. They have been a congregational team for over 55 years, and this coming Sunday is our 166th anniversary here in Newburgh. And we're looking forward to welcoming the Executive Director of Morning Star Mission, Kevin Alkenbrecht, as our guest speaker. The original Methodist church was built on the west corner of this property. And some of the pews from that church are up in the balconies. If you find your pew too comfortable, try those benches upstairs. Later next year, in June, Centreville will be celebrating their 180th anniversary, and this is in conjunction also with the 100th anniversary of the United Church of Canada. Newburgh's anniversary this Sunday will be at 10 a.m., not the usual 11 a.m., as when we combine our congregations together, we always have a 10 o'clock service. And this Sunday, our youth band will be making their debut. Housekeeping information. Washrooms are downstairs and towards the front entrance. The stairs over there to your east is your best. Just use the railings because the stairs do twist. Following our time up here, we really hope you will join us downstairs for some lovely refreshments and just an opportunity for fellowship. I want to thank everyone involved in planning for this evening. It's wonderful to see so many people here. And particularly, we wish to thank Dr. Jeff Sloan, who contacted Dr. Philpott's office, inviting her to join us here. This is an opportunity to get to know Dr. Philpott, to share and discuss information in her book, along with gain from her knowledge and experiences, all in efforts to make Canada healthier for us all. Before Jeff introduces our distinguished guest, I would like to share with you some words of scripture. Words from Philippians 2, verses 3 and 4. And I believe these words are a source of strength and humility for Dr. Philpott and for all of us. Do nothing from selfish ambition or empty conceit, but in humility regard others as better than yourselves. Let each of you look not to your own interests, but to the interests of others. The word of the Lord. Thanks be to God. If you have had the privilege of reading Dr. Philpott's book, you will certainly become aware that these words of Scripture are in fact living words for her. Let us pray. Gracious and ever-present God, our Creator, make your presence known among us this evening. Bless this opportunity of hopeful sharing and learning, that throughout this evening your Spirit will guide the discussions and our responses to what we have all gained in this sacred time together. Bless this time and the fellowship and the nourishment to follow. In Christ we pray. Amen. I invite Dr. Jeff Sloan now to introduce our guest.
Thank you, Barbara, and I'd like to extend my welcome to everyone here as well. It's wonderful to see so many people here, many of whom I know, some of whom I don't. Some of you are my healthcare colleagues from the Napanee area. And it's good to see so many people here to join us this evening. I've been a family physician for probably more years than I should, but I think I'm pushing 42 now. And just to let you know, I'm not taking new patients. In my semi-retirement, I'm working actually for other physicians in the area, and I enjoy so much continuing to work with my colleagues and the capable staff who make my work really a joy. So it doesn't feel like work to me. I go in every day, and it's generally a pleasure. Dr. Philpott is also a family physician, and she and I have had a sort of a brief acquaintance a few years ago when the Queen's undertook the responsibility for organizing and executing the immunization for COVID vaccines, the first round of COVID vaccines in Northern Ontario First Nations and Queens, and Dr. Philpott were very instrumental in organizing and executing that program. And I had a great privilege to participate in that. It was a wonderful experience for me. And Dr. Philpott was there in the background, always encouraging us and available to help us troubleshoot in those early days of COVID, which, as we all know, were very scary times. So that's where I first had acquaintance with Dr. Philpott. And as you know, she is the Dean of the Faculty of Health Sciences and the Director of the School of Medicine at Queen's. She's the CEO of Southeastern Ontario Academic Medical Organization in Kingston. She's a professor of family medicine, as you know, also a former member of Parliament from 2015 to 2019. She served as Canada's Minister of Health, the first physician to serve as Canada's Minister of Health. She is Minister of Indigenous Services, President of the Treasury Board, and Minister of Digital Government. And prior to politics, Dr. Philpott spent the first decade of her medical career in Niger in West Africa, where she worked and then she worked as a family doctor with Markham Stouffville Hospital for 17 years, including 6 years as the Chief of Family Medicine. Dr. Philpott, welcome to Newburgh, and we are extremely interested and honored to have you here and to hear you speak about your book and your experience and your knowledge about primary care and some of our hopes for the future. Many of the people here have gray hair, and including myself, and we are somewhat anxious about accessing healthcare in the years ahead, and we're very hopeful and anxious to hear some good news from you this evening, so thank you so much for coming.
Well, thank you very much, Jeff. I'll maybe make a few opening comments. I know that you have planned to make this largely a question and answer time. And I know that you have some questions ready for me, but may I begin by thanking you for the wonderful invitation to be here. What a beautiful place this is. What a wonderful building in which you gather. I see lots of faces in the crowd that are friendly and familiar ones, so that's really nice. I gather this little Amherst Island contingent that have arrived tonight, which is great, and so exciting to see my friends Kim and Kenny from Napanee, who have always been very welcoming to me, and this is a beautiful time to be able to gather together. I want to thank you for being interested in the topic of health for all. As you said, it's something that affects all of us. Without health, little else matters, and as I say in the book, without health for all, everyone suffers. And so tonight I look forward to an opportunity to engage about the book and about topics that are related to the book. And I want to thank you for giving me an opportunity to share some of these ideas. My hope is that you will go away feeling hopeful, because I do believe that despite some of the grim realities that we'll talk about in terms of the data around access to health care that we're experiencing in Canada right now, that there are solutions,
that there are many people working toward those solutions, and that in fact we can do much better for the people in our communities, for our families and loved ones, if we work together and try to find ways that in fact we can ensure that every Canadian will have the opportunity to enjoy the highest attainable standard of health. So with that, Jeff, I'm going to pass it over to you to grill me with questions.
All right. And on the pews, you'll notice there are little cards, little white cards and pens at the end of each pew. So if any of you have any burning questions that you'd like, please write them down. And Roman, and I hope Rosie is out here somewhere, will collect those and deliver them to the front. Okay? There's 4 or 5 cards and a pen at the end of each pew. So please feel free to put Dr. Philpott on the hot seat. So, Jane, what was your purpose in writing this book, just to start off?
Thank you. The hardest questions first. What was the purpose in writing the book? Well, there are several of us in the room tonight, I think, who have been involved in healthcare for decades. I think it's fair to say, Jeff and I share that I've just hit the 40-year mark from my graduation from medical school, and I know there are other medical school graduates here. We think a lot about not just the patients and individuals that are in front of us, but over time, and actually fairly early in your medical career, you start thinking about what is it that actually makes people sick and what actually keeps them well. And you start to imagine the systems around wellness and health, and the fact that doctors can actually only do so much to be able to help people be healthy, but the way that society is structured, the rules that we've set up for ourselves actually are even more important in terms of who becomes sick and who has an opportunity to get healthy again. And so I was reflecting on a lot of those things, especially in the early days of the pandemic, Jeff, when you and I met each other, and had an opportunity to start spending a little bit of time writing down some of my ideas around what I had seen about health from my personal life, from my life as a family doctor, from my time in government as federal minister of health, and then more recently at Queen's, where we're in the business of training the doctors and nurses and physiotherapists and occupational therapists of the future. And I discovered that I had opinions about this. And just as I started to write and formulate a bit of a hypothesis about what I thought was at the root of our crisis in healthcare, it seems that I actually enjoyed the writing a lot and started to have conversations with the publisher, and didn't quite know exactly which direction the book was going to go, but the publisher said, you know what, there's a crisis in healthcare. If you have solutions, you should finish this book. And so it was a really interesting exercise to think through how you put all of the possible conversations about health into a book when you can look at a little bit like the elephant that the blindfolded people are looking at, and realizing that if you only see the tail, then you only understand a little piece of the elephant, or if you only have access to the trunk, you only understand a piece of it. And health and healthcare can be looked at from so many different perspectives, but I picked a few of them. I wanted to talk about health systems because that's what people think about first in healthcare. But as you know, Jeff, I also got into issues like social determinants of health, political determinants of health, and as people here will possibly be interested in, I also had a whole section on spiritual determinants of health. And somehow it all came together in a book, and I've been delighted with the fact that it started what I think is hopefully a helpful conversation.
So the second message is somewhat related, and it's a bit vague. I think I generated this question. What's the message that you want to send to Canadians about healthcare?
Well, the most important message I want to send is that we can do better, and there is reason to hope. It's very easy to despair in healthcare, and those of you who work in healthcare on a daily basis get surrounded by despair. It's exhausting. People are work incredibly hard, and you see long lineups of people, sometimes physically long lineups, but also you know that there are people that are waiting months for access to care. And it can get kind of discouraging. And there's a bit of a public mythology around the fact that it's just unfixable, that we're never, you know, we've gotten ourselves into a big, complicated mess, and we might as well throw up our hands and let private companies come in and solve our healthcare system, and that's really the only thing that's left to do. And I heartily disagree with that. I actually think that the solutions to improving our health system are not that complicated, and we've never turned our mind to them as Canadians. It's come as a bit of a surprise to us because, as you know, Canadians are very proud of what we've done on health, and we have reasons to be really proud. You know, back in the 40s and 50s and 60s, some really smart leaders got together and started to look at arranging systems of insurance for doctor care and insurance for hospital care. And thanks to people like Tommy Douglas, those were started in one province in Saskatchewan and eventually crossed the country. So what we have in Canada is this incredible national insurance system, so that we know that medically necessary services will be provided based on your medical need and not based on your ability to pay. But we kind of, after the 1980s, rested on our laurels and thought this was great, we've got the best healthcare system in the world, we're so proud of it. And nobody gave it the maintenance that it needed to be able to keep up with the times, where care isn't just provided in hospitals and care isn't just provided by doctors. And we didn't actually ever design a system, particularly a primary care system, that would ensure that everybody had access to primary care. So the book talks about some of the solutions. I'll go into those as we move along in some of the conversations, but the main message is that we can do better. There are many countries in the world that do better than us. There are many countries in the world where every person in the country is assigned to a team, a primary care team, based on their geography, just as automatically as we in Canada assign every child to a public school in their neighborhood. We could do that in healthcare, and people like him are some of the people that are trying to make that happen. And it's actually not that hard, and it's going to change the face of healthcare if we are successful in this.
Thank you, Jane. Can you tell us a little bit more about the primary healthcare system? Is it in Norway that we're talking about?
Yeah, so there are many countries that do better than us, and by do better than us, I mean that actually spend the same or less than we do per capita on health, but get better health outcomes overall. Longer life expectancies, shorter wait times, more equitable access to care. And they're mostly European countries, so the Scandinavian countries are the classic example, Norway being probably one of the best in the world. The Netherlands also has fantastic access to primary care. Even the UK, for some of you who may have connections to the UK, and you know, the NHS gets a bit of a hard rap at times, and some of the doctors are not always happy with how the NHS works, but when you move to the UK, or if you live in the UK and you move to another community, you will automatically be assigned to a health home in your neighborhood. And there's no questions asked. It's automatic as signing your child up to school, and that's the place where you can go. You can access your medical record that is actually shared across the entire country, so that if you lived in Birmingham in the 1980s and you suddenly moved to Sussex in 2024, your records from your time decades ago are still in the NHS system, and you are automatically assigned to a doctor in that community. Canada never did this. We developed this very hodgepodge ad hoc system where doctors set up shop wherever they happen to want to set up shop for all sorts of personal and professional reasons. But we never organized ourselves to make sure that people are assigned to a health home in their community based on their geography. We're really lucky here in this region because we have fantastic leadership of our local Ontario health team, and we are moving, not as quickly as everyone would like, but we are moving slowly but surely toward a system where everyone in the Kingston, Frontenac, Lennox, and Addington area will have a health home in their community. It's really exciting. People are watching what's happening here in this region. It's not because we had things great, but it's because we realized we were in a crisis time where 30,000 people in the region didn't have a family doctor, and we're gradually tackling that. And my dream is that we can do that across the province and then across the country.
Thank you, Jean. Next question. This is called the what can we do question. So, toward this vision of health for all, what effective action as citizens can we take if we have 5 minutes, 5 hours, or 5 days a week?
Okay, I love this question. This is really interesting to think about what people can do. One of the things I talk about in the book is, again, the fact that there are solutions out there. We could design a health system based on primary care, and that would allow us to get better health outcomes at a more affordable cost in a much more equitable way. Why haven't we done that in Canada? There are a bunch of reasons, but at the root of it, I believe, is political will. Nobody has had the political will to say, we're going to do the hard work to get this place organized, whether it's this region, this province, this country, and we're going to build a system where every person has access to a primary care team, a family doctor or a nurse practitioner on a team in their community. That political will, though, doesn't just happen overnight. Political will comes from public will. I learned very quickly as a politician that what makes politicians tick is what they think the people want. They're constantly polling the opinions of people to see what's popular. And when they go out and knock on doors, they listen, believe it or not, to what they're hearing at the doors. In fact, there was a very interesting by-election, as you might know, in Quinte just a few weeks ago. And I am told by those who were knocking on doors in that by-election that the #1 thing that they heard from people in the Quinte region was the lack of access to family doctors. That made politicians stand up and pay attention. So I would say, talk to your friends and neighbors about the fact that we're not doing very well, that there are 6.5 million Canadians who don't have a family doctor. That translates to about 2.5 million Ontarians, and as I said, about 30,000 people right here in our community that don't have a family doctor. Talk to your politicians about the fact that you want to do better. You believe that we can do better. I have suggested to some people, and here's where you'll pardon me for a little self-promotion, but if you're not sure how to explain it, read the book. And if you like it, share the book with your neighbor. And if you really want to be an advocate, I have suggested to people, take it to your local member of parliament or member of provincial parliament and say, here, this is what we can do. I have discovered over time that some of those books have made their way to influential people who are paying attention and reading it and saying, hey, maybe we should try and do better. So that's something you can do in 5 minutes, is make the call. The 5 hours you can use to read the first section of the book. What can you do 5 days a week? I think there's an enormous amount of opportunity around volunteering in communities. If you're at the stage in life where you have flexible time to be able to volunteer. Most of our hospitals have done a great job designing systems where people will volunteer in the hospital-based system. I think we need to increasingly have our health system grounded in communities, and the primary care world has not developed a system for people to be able to volunteer in community health centers or primary care teams very much. But if in fact we can be successful in building these models of health homes in every community, I would love to see people that will volunteer to help out and talk to some of the doctors and nurses that are in your community to say, is there a job for me? Could I help people navigate the system? Could I help give rides to people who need to see a family doctor? Help them to be able to follow up with making phone calls. So, and of course you can also volunteer in your local hospital. But I'm trying to encourage people to think that hospitals are not the only part of the health system that need people to give their time.
This is our first question from the audience tonight, and it's somewhat related to that one, but it focuses on family physicians. It says, how can family physicians practicing in the current one-room schoolhouse model help expedite a move towards the primary care home model, analogous to the public school system model?
Yeah, really, really interesting question. So you're quite right that historically, a lot of physicians tended to develop what we call solo practices. They would set up shop either by themselves or maybe with one other colleague or partner that they would set up shop with, and they pretty much ran things independently. And they used a billing system called fee-for-service where they just saw people and billed each time. All of that has changed a lot over the years. And we're trying really hard to train a lot more family doctors, and I could go into some detail on what that looks like at Queen's and elsewhere. But at the moment, we don't have anywhere near the number of family doctors that are necessary to actually meet the needs of all of our communities across the country. But the reality is, and probably some of you have experienced this, is you don't always need to see a doctor. There are many things for which you would have historically gone to see your doctor, and that visit could easily be addressed by somebody other than the family doctor, but someone who worked on the same team. So it might be the nurse or the nurse practitioner, or I love to work with dietitians, for example, or social workers, because often they are far better skilled for what my patients need. And so what we are hoping to gradually transition the system to more is to have people functioning in teams where you will still have an ongoing relationship with a family doctor or a primary care nurse practitioner that's kind of your go-to person over a long period of time that will do some of your regular checkups, but that on any given day, if that person is not available, and there's no doctor in the country that is available 24/7, 365, that you'll be able to be seen by somebody else on the team who shares a medical record with your team and who knows about all of your medical history because it's documented in the record. So some of that's already happening to a large extent, but not as much as it should. And so the idea is to gradually not only start new health homes, like I was talking with someone whose name I've forgotten in the back of the room about the new Midtown Kingston Health Home, which we're really excited about, which is a brand new team that we've put together. But to also say, how can we actually take individuals or groups that are currently working separately and try to bring them together to work more collaboratively. And there's an amazing project happening in Napanee around bringing together groups who had formerly been somewhat separate. And some really genius work has been done with those collaborative teams to be able to bring them together. So I'm excited about what that will look like and what it would look like if we could reproduce what's happening here in this region everywhere across the province. I think we will be in a lot better situation.
Not to focus strictly on family physicians, but can you offer any insights into why medical students these days are choosing specialties other than family medicine?
Yeah, great question. So this has us all quite worried. We have fantastic medical schools in this country. I'm very happy to be very proud of the Queen's Medical School, which has grown now recently for the first time in a generation. We actually grew the size of our medical school. And part of the hope is as you grow medical schools that this will produce more family doctors, but simultaneously with the growth in medical schools is the diminution in interest in becoming family doctors. And so currently across the country, only about 30% of our medical students choose family medicine as their first choice in their matching system. And it needs to be significantly higher than that to actually address the community need. What's behind that? A whole bunch of things, and I propose some theories in the book about why it is the case. I think probably the biggest reason is that it doesn't look like very much fun from the outside, because these doctors are all quite burned out by the administrative burden. They've done studies that show that an average family doctor will spend 19 hours per week on paperwork, and they get trained to do clinical work, but they end up, staying at their desk till 9 or 10 o'clock at night, just answering all of the messages that are in their inboxes, and organizing referrals and filling out forms and those kinds of things. So we've got some sort of work-life administrative issues to work out. I won't bore you with all the details of how those things are going to be better in our proposed new systems, but we do have some evidence that by putting people together in teams, offloading some of that administrative work to other people on the teams other than the doctors will help. Just the possibility of working in a team will make a medical student or a resident think more about the possibility of practicing family medicine. We see our residents, who are the graduated doctors who have been training in family medicine, training in teams, and they say, I love working in a team. I love being able to have a nurse or a dietitian on my team who I can share my workload with. But we don't have funding models in most of Ontario right now where it's possible to do that, until very recently, as there started to be a bit of interest in that. And so these young doctors will finish their training and then they'll say, I don't want to go out and hang up a shingle like my father or my uncle did. That's not the way they want to practice anymore. So some of it is just changing what we call the conditions of work to make it more attractive, and it's not easy, but I think there's some good moves in that direction.
Somewhat changing the focus here. There are two related questions here. Canada's geography impacts delivery of healthcare. What tools are available to help ensure that rural and remote communities, as well as major urban areas, can be supplied with similar health services? And it says Canada is unique because of the vastness of geography. How can we better serve rural and isolated communities?
Great question. So, when I share examples of countries that are doing really well in primary care, where they have 99 or 100% of their people attached to a family doctor or primary care team, and I start to talk about places like Denmark and Norway, there are several people who will say, well, that's easy. They don't have the vast geography of Canada. Like, we'll never be able to do that. We've got this big old country. And I say, no, we can't use that as an excuse. And you know what my best rationale for that is that we figured it out for public education. We never used that as an excuse for public education. We didn't say, oh, well, people, children in rural Saskatchewan, they can be left out because it's just going to be too hard for us to be able to get schools. We figured out how to do it. And I recently had a really fascinating conversation with one of the professors of the Faculty of Education at Queen's, a guy named Ted Christou, who is an historian of public education. And he described to me what it was like, how we developed our public education system. It was quite fascinating. It's actually older than the country. Even before Canada formed as a country, there were laws that talked about universal public education. And the creativity that people before us came up with as to how you were going to make it possible for children in remote and isolated communities to have access to schools was quite remarkable. So he described to me these things like the school trains. Has anyone ever heard of school trains before? That would actually travel from community to community, stay for a little while, leave books and assignments behind, and move on to another community where they would also visit a group of children in the next community, and then eventually started to build one-room schoolhouses even in small towns. And communities made sure that no matter how small their village was or how big their city was, that we would make sure all of our children would have access to public education. We have to have that same kind of commitment when it comes to access to primary care. Yes, we will be able to develop more creative models, and of course there are much more opportunities now for things like virtual care, so that you might, in a more rural neighborhood, not necessarily physically visit your doctor or nurse practitioner on every visit. And you might have more nurse practitioners perhaps in some communities where it's harder to find family doctors for those communities. But we don't give up on people because they live in rural and remote areas, and we don't throw up our hands and say it's not possible. Because to me that is one of the fundamental obligations of governments and society, is to make sure people have education and people have health care. It really will require a little bit more creativity, but if we can do it for schools, we can do it for healthcare.
This may be a little bit beyond the scope of your study and your work, but access to specialist care is also becoming an issue in Canada. Those of us who are family physicians know that wait lists are getting longer and longer. So access to primary care is important, but what about secondary and tertiary care?
So I think it's a fantastic question, but as those of you who are involved in healthcare will know, it's all interrelated, right? So, I have talked a little bit about what the data are like, and when you're working in the reality that writ large across the country, about 22% of the population doesn't have access to primary care, what do those people do? I mean, maybe there's some of you in the room that don't have access to primary care, but if you don't suffer that way yourself, you probably have friends or family members who don't have. And what ends up happening is that you're not getting screening regularly for cancer screening and other kinds of health screening that needs to happen. You're not having your chronic diseases managed, so your diabetes or high blood pressure or high cholesterol. You're not getting the health coaching that you need to have. And those are the people that end up needing specialty care because their illnesses get further advanced. And so we have now emergency departments. I'm not sure what the data is like at Lennox and Addington County General Hospital, but in many hospitals across the province, up to 25% of the people who present in hospitals don't have a family doctor. And so they are the ones that need to immediately be referred to specialists to manage things that ideally a family doctor can often do. And many of the referrals that specialists are dealing with are not because a family doctor couldn't take care of them, but because the person doesn't have a family doctor to be able to care for them. And that's part of why we end up with specialists who have wait lists of a year, 18 months, 2 years, etc. There are some creative things that are starting to happen more and more around trying to manage those wait lists in better ways. We've really not done a great job on managing wait lists for specialists in this province for some bizarre reason. Even our banks and all sorts of other places in society, we've learned that if you put people in a single queue, you'll be able to move through the line in a fairer way, that you'll be able to make sure that the person who arrived at a particular time gets access to the queue faster than the person that came after them. But when it comes to our referrals to specialists, as you know, Jeff, it's chaos in the system. In most cases, there are a few places that have organized themselves better, but poor family doctors are struggling to try and figure out, sometimes sending referrals to 4 or 5 different specialists at a time, hoping that one of them will be able to see the patient. I won't go into details about the chaos that results in, but it's absurd. And so there are all kinds of things that we can do that will lighten the load on the specialists, that will allow those queues to run much more smoothly. But at the root of it, we don't have to reinvent a study of what the problem is. At the root of it is the fact that we have not designed a system based on primary care. It's like we were building a house and we didn't finish building the first floor of the house, and we went on immediately to try and solve the second and the third floor. But if you don't have the first floor solid, the rest of the house is not going to be solid.
Great analogy. Here's something hot off the press, like the ink is barely dry. Many communities are offering incentives, but doctors are not allowed to offer services to those outside the sponsoring communities. This leaves many of us with no access. Any suggestions?
So there seem to be a couple different issues that I've heard there. One was around community incentives for attracting doctors, I think was part of the question, and then around people. I'm not sure whether I know exactly.
Well, I think people are feeling a bit disenfranchised because down the road they can see a family doctor because they live in Napanee, but if you're in Stone Mills, they're not part of that program, so they're stuck.
So we are all we are living in an inequitable time where unfortunately, you know, services are not equally distributed, and that is wrong and unacceptable and needs to be fixed. I believe that we're in a bit of a transition time now as we're starting to have places like the Greater Napanee area that are getting themselves organized and have an ambition to say, we want to know that everybody in our community has access to primary care, which is fantastic. But you're right, it doesn't feel very fair to people that happen to live outside of that community. I estimate in the book it will take us a few years to be able to actually get to a world where it will not be an issue and everybody based on their geography has access to primary care. We have not done a great job at mapping out where the gaps are, but that's one thing that I believe the governments need to do, is to be able to say, you know, if we know that roughly 2.5 million people across Ontario don't have access to care, we need to figure out where those gaps are the biggest and focus on filling those gaps first. We can't actually suddenly create access for 2.5 million people overnight. But we have to get started now, and that means that some places will get that access a little bit sooner than others. If anyone can come up with a way to make that more fair, please let me know. I have not quite figured that out. I don't think the people that are trying to solve this problem have totally solved it. Unfortunately, in the short run, until we can actually make sure that there is a health home in every community, there will be people who are left out, but that doesn't mean we shouldn't try to at least start somewhere and eventually have this dream that we can be a country where every single person, based on their geography, no questions asked, that's your health home, you're going to get to see someone there and you're going to get to see them in a timely way.
Thanks. You can't get into a church without some confronting religion at some point. And so the next question is a bit of a shift.
Okay.
What role do you feel religion or faith commitment should play in the political process? We hear a lot always about the separation of church and state. You're very clear in your book about your own faith background and how it influenced you and continues to influence you and your values. Do you have any comments or thoughts you'd like to share on that?
Sure, I think we could talk about that all night, couldn't we? You're quite right. I, like probably many of you, grew up in the Christian church. My dad was a Presbyterian minister. I was just saying, somebody was talking about the Amherst Island folks here. Those of you who were from Amherst Island will probably know Xander Dunn. Xander and Nancy Dunn were great. My dad's deceased now. But my mom and dad used to come out to Amherst Island to visit Xander and Nancy when they were there. So lots of interesting little connections with this area and community. But yeah, I was raised in the Christian traditions, and my faith has been a driving force for my values. How does faith or religion, I think you used the term religion, interact with politics? In the book, I don't specifically talk a whole lot about faith and politics. I talk about faith and health, faith and wellness. And in fact, there's a whole chapter about hope as one of the determinants of people's wellness, especially their emotional or spiritual wellness. And I describe the fact that for me, the source of hope ultimately is my faith. I mean, people can find hope in all sorts of other things, but for many of us, our hope comes from, believing in things that we can't see and trusting in things that we can't completely understand. And so I think that there are real interactions between faith and wellness that we don't talk about very much in healthcare. I'm not sure about the rest of you in healthcare, how much you did, but I wanted to introduce those concepts as part of what I think it means to be well as a whole person. In terms of your more specific question about faith and politics, it's very interesting. I think they are deeply connected in that, faith drives values and values drive the way your political philosophies often. But those of you who, again, I keep referring to those of you who are in healthcare, because I know there are several of you here, we know that while our faith may influence the way we practice medicine or our approach to being a provider, we don't have the liberty of imposing our faith values or beliefs on anybody that we see. We have a responsibility to treat the entire community and to meet people where they're at and to understand their own faith. It was the very same in politics. You know, there were some people that I knew who sort of said, you know, as a Christian politician, why didn't you push harder on your Christian values in politics? And my answer to that was always, it will always inform who I am, but I have the responsibility to be the member of parliament for 100,000 people in my community, and they don't all share the same values as me. They don't all, you know, I don't expect them to think the same that I do about everything, because they have different faith backgrounds, or in some cases no faith background. And so I think these are things that in many vocations, your faith will inform who you are, how you conduct yourself, but not necessarily the content specifically around the particular projects that you work with, and certainly never gives you the liberty to impose your faith values on anybody else. That's not appropriate in medicine nor in politics.
Thank you, Jane, for that thoughtful response. Kind of along those lines around politics and your experience there, you left politics under somewhat difficult circumstances, as most of us know. Many voters have become somewhat cynical about politics and politicians. And in Health for All, you appear to retain a strong belief in the value of politics and the political system in getting things done. Would you care to elaborate a little bit on that?
Sure, I'd be happy to elaborate on that. I don't feel cynical about politics as it should be. I sometimes feel a bit discouraged about politics as it is, but we have to always believe that it can be better. I mean, politics is practiced by fallible people, and so it ends up getting messy and not always the way it should be. But I loved being in politics because it's an enormous privilege to be able to actually influence the way that we organize ourselves. And so I talk a little bit in the book about the fact that I went from medicine to politics because I knew that what makes people sick is influenced by the structures of society, and the people who get to make the rules about how society is structured ultimately are the politicians. And so if you get a chance to actually be able to potentially say, well, the rules aren't fair, I've spent my whole life trying to figure out who makes the rules and get myself into being one of the people that gets to change the rules. And once you get to change the rules, you can actually try to make us into a fairer society. And so that's what politics at the end of the day is supposed to be. It's supposed to be about communities coming together and saying, that's the person that we believe will work the hardest to represent us and to make our society fairer, healthier, safer. Unfortunately, people often go with those to a representative role with good intentions and get sidetracked by a whole lot of influences that are not the most admirable ones. But I strongly always encourage people, if you're remotely interested in politics, please consider it. I'm not sure if any of you are thinking about a future career in politics. I'd be happy to encourage you that way. Do support people who do put their names forward. It's a really hard thing to do. It's harder now than it probably ever has been. But we need good people going into politics for the right reasons, and we need to support them to survive what is probably one of the most toxic workplaces in the country. But to help them stick with their values and make wise decisions despite all of the forces that are working to the contrary.
I'm keeping an eye on the clock here. I'm thinking a few more minutes, a few more questions.
Sure.
2 or 3 more questions.
I'm up for it if you're all not, falling asleep. So.
This one is, I'll try to interpret it, or I'll just read it as it is. What do you think of the idea of specific health homes, such as one geared specifically to OTs or mental health counselors? This would allow family physicians more options for what looks like foundational care. I'm not sure exactly what that means. Maybe you can figure it out, or perhaps the person who wrote the question can elaborate a bit on it.
Well, the way that those of us who've been trying to envision health homes for every community have been thinking about it is that they won't all look exactly the same. I mean, the concept of a primary care home means that you will have family doctors, probably nurses and or nurse practitioners. Those are sort of the basic ingredients along with your administrative team. And depending on the size of the population, there are other parts of the health team that are really helpful to have. I am a huge fan of having both occupational therapists and physiotherapists, and from the mental health perspective, both OTs and social workers are enormously helpful. So I think maybe that's what your questioner was getting at. I mean, could you have just OTs and social workers at health home? Potentially, but the idea is that it should be as diverse of a team as possible, and so that depending on what your particular needs are, you'll be seen by the person that's most appropriate. Some of you will know that family doctors nowadays, depending on your practice, will spend sometimes up to 50% of your cases have some sort of mental health overtones to the needs of the person that's in front of you, and that's why it's really wonderful if you have somebody who can spend more. Doctors often need to see you every 15 minutes. It takes more than 15 minutes to actually have an in-depth conversation and to actually get into the issues if you're going through a difficult time personally. And so I just think that it's absolutely fantastic if you can have experts, and the person specifically mentioned OTs, and if there are any OTs in the room, OTs I think are among the very best mental health experts out there because they really help people get back to function. They sort of realize that you can't always cure all that ails us mentally, but at least you need to figure out how to be able to cope and to get out of bed in the morning and get on with your day and get back to work, those kind of things.
All right. This next question kind of focuses on mental health issues, and it says, with worries about the economy, climate, democracy, substance abuse, etc., I'm feeling like mental health is a massive issue, especially for young people. Do you have a sense of magnitude of the problem, and do you see solutions for meeting this huge need?
Yeah, well, interesting. The last two questions are very similar in a way. You're absolutely right. Mental health issues, and I don't have statistics at the ready in terms of the enormity of the challenge, but your questioner referred to the fact that young people in particular, I think, are facing levels of existential angst that are much higher than they used to be in previous decades. I do think, we've siloed off mental health care as if it's a separate part of health care. The vision that I describe in the book is very much that all of those pieces of care should come together in that health team, and so that home care and mental health care and palliative care should be ideally bundled into the team, not sort of referred out to another separate part of the system. But the other thing that I'll point to, and this is one of the reasons why I put the whole section in the book on spirituality, is that it's not medicine that people need when they have mental health issues in many, many cases. There are obviously some unique cases where medicine is part of what you need. But for those of you who haven't read the book, there's a section where I talk about a framework for looking at what makes us healthy mentally or spiritually. And it's a framework that was taught to me by some Indigenous elders who spent years studying what their ancestors had taught them about mental health. And they developed a framework called the First Nations Mental Wellness Continuum Framework, and it's a fascinating document that you can Google and read all about. But at the center of this framework were the 4 concepts of hope, belonging, meaning, and purpose. And I still remember very vividly the moment that I was shown this framework, and I zeroed in on the center and I said, wow, that's really what it takes for us to be well on the inside. We have to find a way to have hope. We need to have belonging in our lives. We need to make meaning of all of the confusing things that happen to us. And ideally, we need some sense of purpose, a reason to get out of bed in the morning. In my non-philosopher's way, I tried to explore those concepts of hope, belonging, meaning, and purpose with the desire that other people will find it helpful to kind of think through for themselves. You know, what is it that's ailing me? Is it because I don't have meaning, or is it because I don't have belonging? And what can I then potentially do to be able to help with some of those things? So it was the part of the book that I was most nervous about, because I thought this may be a bit weird. This is not a normal health policy thing to put in a book. But I've had so much positive feedback from people who have said that was my favorite section of the book. And it was like, wow, that was, I feel like I'm really glad that I included it.
Again, this may be outside of your scope.
Testing me, aren't you?
Yes. But great questions. Thank you for everyone who's putting these forward. We may not be able to get through all of them. Keep coming. Question here is, the health home is consistent with a community health center or CHC model of care. And this person says, my understanding is that the CHC model is not affordable for all. How is a health home different? And the second one, which is somewhat related, will the health home model provide pay equity for non-MD providers? Currently, that is not the case.
Okay, really, really interesting question. So I won't go into tons of specifics because not everybody's interested in the details of health policy, but these are really interesting questions. So I keep looking at Kim because Kim is my partner in crime. It was not crime that we're committing, Kim. We're trying to fix things, but Kim and I spend a lot of time talking about these things and sort of imagining and dreaming what the models are. She actually does the hard work to implement some of this stuff. And we've sort of looked at what the best kind of models are for what a primary care health home should look like. And in fact, when we designed the Midtown Kingston Health Home, what we did was try to take the best of multiple models and put them together to see if we could come up with something that works really well. And the person who wrote the question is quite right that the community health center model is probably, I think, has the best outcome measures associated with it, is perceived to be expensive. But one of the reasons why it's perceived to be expensive is that we've largely, in Ontario and elsewhere, only used the community health center model for populations that are some of the most high needs populations and where they're sort of more structurally marginalized or low socioeconomic populations. We haven't tried to take that CHC model and use it for an entire population where not everybody needs a half-hour visit as a CHC might ordinarily do. And so what we've tried to do is take that model and say, what if you actually used that and said that this is a model, but it's here to care for the whole population, whether the person needs a 5-minute visit or a 45-minute visit. We think that we can actually be able to make the system more affordable. So that's roughly the vision, which is an ever-evolving vision. In terms of the pay equity issue, that is a big and complicated one that I won't dive too far into, except to say that what we have tried to do as well is to use the negotiated compensation that CHCs have negotiated, which is better than it used to be, but there is still a very serious challenge in the fact that community practitioners almost always are paid less than their counterparts in the hospital system, with some exceptions. And so there are some very significant pay equity issues that will continue to trouble us, but we need to advocate for fairness on that one too.
I think we're pretty much ready to wrap up.
Okay.
Unless there are any other questions that people want to just offer verbally. We don't have a microphone set up, so you have to speak up. Last call. Okay. At this point, I'd just like to offer some thank yous to Bill, who does our sound system, does a great job with it. I'd like to give thanks also in advance to Lorraine and Susan, who have done our table downstairs. If people are interested in staying for coffee and snacks afterwards. And for Rosie and Roman for doing our ushering and bringing the questions forward. And also Rosie, I believe you'd like to come and say a few words as well. Rosie Hyde is the chair of our official board, and I think she'd like to say a few words as well.
Thanks, Jeff. My name is Rosie Hyde. I'm the chair of the official board of this Newburgh Centreville Pastoral Charge of the United Church of Canada. And it's my privilege tonight on behalf of the Pastoral Charge to thank Dr. Philpott. 35 years ago, when Dr. Philpott was arriving in Niger, I was wrapping up a 3-year posting as a teacher just south of there in Nigeria. So I'm very conscious that when we go as Canadians to work and help overseas, we try to bring something of value from Canada to our posting, and we try to do valuable work in the host country, and we try to bring back learnings, possibly profound learnings, home to Canada in the hope of strengthening this country here. When I read Dr. Philpott's book, Health for All, it was clear that she did all 3 of these things, and that she continues to build on what she learned in Niger and from other countries around the world. Dr. Philpott, you've given this evening to help us present here to be part of learning how Canada can do better at Health for All. From all of us, thank you.
Just one last item or two. I forgot to mention Ken is doing our videotaping, so people who are interested in seeing the presentation later on YouTube, or people who couldn't be here this evening and would like to see that, it will be up on YouTube within probably 24 hours, thereabouts. So thank you, Ken, also for doing that. And finally, I'd like to, I have a surprise for Dr. Philpott. Those of you who have read the book will know that one of her first activities as cabinet minister was to organize the Syrian refugee program in 2015-2016 that brought 25,000 Syrian refugees to Canada. And some of us in this room were involved in sponsoring a family. And the Hosny family arrived in February of 2016, and they're here with us this evening, and I wanted to introduce them to you as the person who was responsible for putting that massive project together with very short timelines in a most impressive way that allowed our community to have the wonderful Hosny family. Many of you here will know them. Majid is a handyman and has done a lot of work actually in this building for us and in the community as well. And his wife Roseanne is a very good cook and does some catering work herself. And their children are being educated here in the community, and their eldest just graduated from community college in Belleville. And the second eldest just graduated from high school, and their fourth child, the daughter, is graduated from grade 8. Wow. So they're very much part of our community, and we thank you for all of the work that you did on that program as well. So, thank you. Thank you.
Nice to meet
Nice to
you.
meet you, too.
I'm so happy that you're here. Nice to meet you.
Yes, you.
You-
Royal.
I'm Roger.
Rosanna.
Lovely to meet you, Rosanna. Welcome.
Son.
Hello. Congratulations, Mohammed. Yeah, it's wonderful.
And we're missing Mohammed, who came
Yes, Mohammed is actually.
Oh, okay.
last night.
Okay.
So,
Amazing. Oh, thank you for.
Thank you.
so please join us for coffee, coffee and conversation downstairs. Is there anything else I've forgotten? Anyone knows? No? Thank you all for coming this evening and making this a wonderful event. And we hope you all take some.